Long QT syndrome. Long QT syndrome or LQTS is an inherited condition associated with delayed repolarization of ventricles. A normal corrected QT interval is less than 430 milliseconds in males and 450 milliseconds in the females, while a prolonged QT is caused by mutation of ion channel which lead to prolonged action potential duration, which is associated with function mutations. The loss of function of potassium channel lead to decrease and outward current and gain of function of sodium channel or calcium channel which lead to increase and inward current. Mutation or disproportion in channels disproportionately lengthen the action potential in M cells, which lead to increase the difference in refractiness in the different layers, causing electrical impulses to travel around in loops and form a re-entry pathway which lead to torsade de point wave pattern, which literally mean the twisting of the points or the peaks. The most common variant of LQTS is LQT1 and LQT2 caused by defect in alpha subunit of slow delayed rectifier potassium channels. Causes involve congenital Churval-Lang-Nielsen syndrome associated with sensor and neural deafness and is due to abnormal potassium channel. Romanov-Ward syndrome, which is autosomal dominant, not associated with deafness and can lead to syncope and sudden death. Drugs involve amiodarone, sotalol, class 1A antiarrhythmic drugs, tricyclic antidepressant, selective serotonin reuptake inhibitors, especially citalopram, methadone, chloroquine, terfenadine, erythromycin, haloperidol, and others. The electrolyte imbalance involve hypocalcemia, hypokalemia, hypomagnesemia, and acute myocardial infarction, myocarditis, hypothermia, and subarachnoid hemorrhage. All of these causes can lead to LQTS. It is important to recognize as it may lead to ventricular tachycardia, torsade de point, and can therefore cause collapse and sudden death. Features can be picked out on routine ECG, following a family history, and on clinical manifestation. Schwartz score involve the parameter endpoints which help in diagnosis of LQTS with an electrocardiogram finding of QTC time, a 4-minute recovery QTC after exercise test, presence or absence of torsade de point, T-wave alternance, notch T-wave, and low heart rate for age. Clinical manifestation involves syncope with stress or without stress and congenital deafness. Family history with a family member with definite LQTS or an unexpected sudden cardiac death with age less than 30 years in family members. LQTS is diagnosed when the scoring is more than or equal to 3.5 or suspected when the scoring is 1.5 to 3.3 points or unlikely when the score is less than 1 point. The types of congenital LQTS involve LQTS1 with mutation in chromosome number 11 and ECG finding of short ST segment, broad-based slowly generated T wave leading to ventricular arrhythmia during exercise, emotion and stress. LQTS2 with mutation in chromosome number 7 with a normal ST segment on ECG with flat double peak T wave leading to ventricular arrhythmia during exercise, emotion, stress and sleep. LQTS3 with mutation in chromosome number 3 with a long ST segment and narrow spike T wave leading to ventricular arrhythmia during rest and during sleep. LQT1 with broad-based T, LQT2 with notch T, and LQT3 with a late appearing T wave. The clinical approach to congenital long QT syndrome can be done by assessment, risk stratification, and treatment. Assessment by evaluation, history taking and pedigree, ECG, exercise ECG, and genetic testing, while diagnosis made by Schwartz score of more than 3.5, genetic testing, and with the QTC of more than or equal to 480 ms in females or more than or equal to 470 ms in males. Risk stratification by established marker by cardiac arrest, QTC, cardiogenic syncope, and other markers by age, sex, and genotype. Treatment could be conservative, pharmacological, and interventional. Conservative involved to avoid QT prolonging drugs and to do safe exercise. Pharmacological involve beta blocker and mexiletine Interventional involve atrial pacing, left cardiac sympathetic denervation, and ICD. ICD is only in the high risk patients. Question. A 35-year-old woman is admitted to the emergency department following a collapse. An ECG show a polymorphic ventricular tachycardia. Which one of the following is not associated with an increased risk of developing torsades de pointes? In this case, it would be hypercalcemia, because as we know, hypocalcemia and not hypercalcemia cause prolongation of QT interval and hence may predispose to the development of torsades de pointes. Thank you for watching and subscribe.